Thanks so much. And we've been very fortunate in San Francisco from the beginning of the epidemic, where it was very concentrated. We were one of the most heavily impacted cities to begin with, that the community really came together and created a wide variety of programs, partnered with providers. We had really cutting-edge research, and then we also had a lot of support from both national and local government, including the health department. And so we've really moved forward, and I could talk about the 90-90-90, but we're at 94% of positives are aware of their status, and we're approaching 90% in terms of antiretroviral treatment and viral suppression among those who are being treated. But what I want to talk to you about today is the gaps that are remaining and how we're trying to address that through a collective impact approach, and our goals to get to 0 new infections, 0 HIV deaths, and 0 stigma and discrimination. Nothing to declare. So we have been heading towards 0, and if you go back to 2002 when we first had HIV case reporting, we actually had over 800 new diagnoses, and at the peak of the epidemic in the early 90s, we had over 1,600 deaths per year. And you can see that now we've been slowly going down in the number of both new HIV diagnoses and deaths. And that's because of, again, this infrastructure that's been built by the community, by providers, by the research community, and by our health department. There are a few other things that I wanted to just highlight since 2006. 2006, we removed the requirement for written informed consent for HIV testing. In 2010, very importantly, we had a policy to offer treatment to everyone, regardless of CD4 count. I want to credit Diane Howler with leading that effort at that time, as well as a big push to scale up HIV testing. 2011, a citywide program to link to comprehensive services individuals who were HIV positive. And then in 2012, we started our PrEP demonstration project. So we think all of these things have really contributed to where we are today. But at the end of 2013, on World AIDS Day, we had a community forum and talking about getting to 0. We had a number of presentations, over 150 community members attended, a lot of interaction. But at the end, one of the community members said, this is really great, but are you all working together? And we realized we were working together in a collaborative sense on individual projects, but we didn't have a collective impact approach. And so that was really the genesis of our Getting to 0 consortium, which is based on collective impact, which is a long-term commitment from groups from multiple sectors of the community to solve specific social problems. And as much as HIV is an infectious disease, it's also clearly a social problem. And what you can see here is just a schematic of a steering committee that we have. We have over 100 members currently in the consortium. We have partnerships, and we are also partnering with industry. Collective impact is really based on these 5 principles that everyone is working towards a common agenda. So all of the goals and efforts are aligned, that we have common process measures and outcome measures. This is really about action and results, not about just trying to get there. Mutually reinforcing activities, continual communication between groups, and the backbone organization that really is what's needed to be able to sustain a collective impact approach. And what I'd say is that's one place where we have still quite a bit of movement to go, because we only have a 0.25 FTE right now devoted to trying to manage this entire project, and everyone has been incredibly committed and donating their time in addition to their other day jobs. So our strategic priorities are to improve health for people at risk for or living with HIV, and that's in a comprehensive sense with an emphasis on underserved populations, creating innovative programs that build upon the structure of what's already existing, securing multi-sector funding and support, so this is not any one group or one government's responsibility. It really is, it's got to be a full level of community support, as well as exchanging best practices with other cities. And we are eager to learn from all of you, as well as have you come and visit us and take what would be useful for you from what we're doing. So we decided in our first year to start with 3 signature initiatives: PrEP, a comprehensive PrEP program for the city, rapid antiretroviral treatment with treatment hubs, and patient-centered linkage to care engagement and retention in care. And that formed the basis of 3 different committees that have been formed, each of which is coming up with its action plan, its metrics, milestones, and a budget. So PrEP is probably the most complex of the groups because it's the newest, so it had the least infrastructure. We have 3 subgroups: a user subgroup, a provider subgroup, and a metric subgroup. And just again, everything starts with the data that drives our decisions about what we do and how we do it. And so these are the new diagnoses by risk group in San Francisco, and you can see that we have, unlike many other parts of the country and parts of the world, it's really a very heavily concentrated epidemic in men who have sex with men, and the blue line here is men who have sex with men who also inject drugs. So that is our primary population. If you look at the rate per 100,000 of new diagnoses, though, we have the same racial and ethnic disparities that have been described by others. This is for African Americans, which fortunately the numbers are coming down. Latinos, the numbers are not coming down quite as dramatically. And if we look by age, we can see that now the group with the highest number of new diagnoses are the 18 to 29-year-olds. So although we're not seeing the same kind of steep increase in new diagnoses among that population nationally, we aren't seeing the declines in that population that we really need to see in order to address the epidemic. So I mentioned that we have a 3-pronged approach to PrEP. I'm not going to be able to go into the details. I'm happy to answer questions afterwards. We have a group that's really scaling up provider capacity to provide PrEP and knowledge, potential PrEP users to reach out to them, to educate them about PrEP and to increase their access, and then to measure PrEP impact, which has been challenging because it's not a reportable procedure in the same way that HIV infection is. And so we're using a variety of novel strategies to try to get at how many people are on PrEP and how are we addressing their needs. In terms of rapid linkage to care, what I wanted to say is we're doing great. We have, in 2012, we had 89% of newly diagnosed individuals who were linked to care within 3 months. But if we define linkage just as that, then what we miss is that we get them into their first appointment, but we're not keeping them there. So this is the total retention in care just 3 to 6 months after diagnosis. And you can see that we're losing about a third, more than a third, of all of the newly diagnosed individuals. But we've got some disparities, again, with African Americans and with youth. And so what we need are programs that are really going to not just link people to care, but integrate them into care and provide all of the services that they need. And so I'm going to tell you about RAPID very briefly. I want to point out that Chris Pilcher is doing a presentation on Wednesday at the meeting on RAPID, some of the first results from this program. It was piloted since 2013 at San Francisco General Hospital. 55 patients have been started. It's expanding citywide, and it is about getting care immediately upon infection. Retention is challenging. This is the number of new diagnoses that have the case fatality rate for HIV-associated deaths, and you can see that that's been going down, that the number of non-HIV deaths has stayed pretty stable, but we've got to think about how we define what an HIV-associated cause of death is. The cancers and cardiovascular disease, those are both high and may be HIV-associated. Clearly, though, drug overdose and suicide are preventable, but they're not HIV-associated. And so we need to bring those down as well and not ignore all of the other issues that people living with HIV are facing. And so I'm going to stop by ending with the stigma committee, because we won't get to where we need to get to unless we address stigma. And so we have a broad constituency of individuals now who have joined this stigma committee that are supporting the work of each of the other 3 committees, as well as getting prepared to lead a more comprehensive stigma approach. So I showed you where we've been. This is where we now are at: 302 new diagnoses, 177 deaths. But in order to get down to 0, we need to tug those curves down even more forcefully. And so that's what we're trying to do through this collective impact approach. And these are the members of the steering committee. Thank you very much.